Good evening to all. First, I welcome Dr. Raghuram Rao, AD General Central TB Division, Ministry of Health and Family Welfare, GOI, and Dr. Nirmal Jo, Senior Regional Director, Health and Family Welfare, GOI, and Dr. Asha Frederick, State Program Officer, TB, and Dr. R. Pirabu, WHO TB Consultant, and Dr. P.Rajeswaran, Social Health Specialist, REACH NGO. I welcome you all, sir. First, the vital role of primary care to overcome challenge in TB elimination. That is the panel. First question is, what are the current barriers to detect early TB diagnosis in primary care setting, and how can they be overcome, sir? Question over to Dr. Raghuram Rao, sir.
Good afternoon, everybody, and thanks to the state government of Tamil Nadu for organizing this. Very happy to be here, and also happy to see how the public health cadres in the team. So, with the primary care, the question that we are trying to answer, to answer this question, it is not possible to answer from Delhi. So, yesterday and today, I went to the field. In Coimbatore, I went to urban area, rural area, public sector, private sector, spoke to patients in Coimbatore and in Tanjore. And so the answers is based on that, right? So first of all, at the primary care level, the comprehensiveness is not there, in the sense that for tuberculosis, it is vertical. So the MLHP or the field people have limited role in tuberculosis, apart from just maybe any symptomatic they find in the community, refer them, and then we get tested. What happens is that we miss cases, or when we find cases, it is passive. It is too late. They are so late that we have a very high death percentage in Tamil Nadu as compared to rest of the country. And there are multiple factors why death is high, including comorbidities and low BMI, primary reasons for that. But when I want to add it as part of primary health care, then I think we should first articulate the health cadres. There is a health inspector, there is a MLHP, there is women health volunteers, male health volunteers, and then an MO. In that, apart from the MO, the others have very limited role as of now, and that too at primary health center and above. But below that, at the community level, there is limited role that is being played. So I think we need to define the roles for each in terms of, one, which population in the PHC area is TB going to occur from. You've done your own prevalence survey in Tamil Nadu. Wonderful exercise, wonderful insights from the data. But the data is useless unless we put it to action in the field. That action is that all my sub-health centers, all my PHCs should have a line list of those population which account for 80% of the TB cases in Tamil Nadu. And that is just around 6-7 categories. And there's a very standard principle in management, a 80-20 relationship. So 20% of the population in the district is giving you 80% of the cases of TB in that district. So focus on them, and the focus should be on early diagnosis and prevention. That's the reason why, because when we catch TB, it is too late, and we have 8, 9, 10% mortality that is happening. So there, as part of primary care, the job of the peripheral staff is to know which population, regular screening at the health and wellness center and the PHC as part of master health checkup that we do once a year. But here in this population, let us get them to the PHCs and sub-health centers at least once in a quarter. Try and get an X-ray. Without an X-ray, even in the prevalence survey for Tamil Nadu, we have seen half of the cases are asymptomatic. And hence, if you don't do an X-ray, they'll wait for symptoms to develop, and then when they come, it is a full-blown TB case, 3+ max. We see that in the microscopy and TrueNat. So early detection, one, is in terms of the field to be able to pick up the population, catch them, make it part of routine job. Unless it is part of routine job, it is part of the key performance indicators which the block MO reviews with the PHCs, the district reviews with the blocks, the state reviews with the districts. Make it a key indicator as part of primary care. And once we start doing that, automatically it is ingrained, and then they start looking for it. So early screening, reaching out to the right population, collecting the sample, putting in mechanisms by which we are able to decentralize our diagnosis and treatment. Sub-health centers currently do not have TB medicines in Tamil Nadu, but we can. When we have a MLHP now, we can decentralize TB care to the sub-health center level where treatment can happen. There is telemedicine, but it is not getting used for TB, right? So you can always utilize the 12 package of services in the health and wellness centers that has now been given. Of that, all the other packages have an implication for TB. 30% of the population of TB have diabetes. So the NCD program is important for you all to do that. So what is happening is all these programs are in silos. There was a wonderful proposal from Tamil Nadu on the one-stop center, right? Now that's a concept where, irrespective of why somebody has come into this, you provide all services in one window, in one opportunity. So it's opportunistic screening for everything. So I think that is something which, if we are able to do it at the block and at the PHC level, where everything, all your priority programs, we have done epidemiology, all our public health people here will have seen, what is driving what disease in which population in the community. That's where I think we need to focus, and you do that in terms of activating the one-stop centers and the comprehensive primary care at the PHC and sub-health center level. We need to take TB down to the primary care level. As of now, 80% of the diagnosis is happening block and above, which means that primary level we are missing those diagnoses. They would have walked in, they would have definitely walked in for something or the other, but we would have missed, an opportunity for screening them. So I think that's probably the way forward. And you'll have been able to up the testing rate over last 2-3 years to almost 3,000 per lakh population, but the number of cases is the same yield out of it. Then we say, why are we not getting positive cases in the field? Also, I have increased the testing rate. You told us to do that. We have done that. The cases are not coming. The sample that is collected, is it coming from the population from where 80% of the cases are going to come? Unfortunately, no. So we are testing, but we are probably testing the wrong population, and we are missing X-ray in terms of the screening level. So we'll be able to prioritize. I think that those are actions which in primary care, if we make it an integral part, definitely TB, both incidence and mortality reduction can happen and will happen in Tamil Nadu. I'm sure we have the systems to do that. Yeah.
Thank you, sir. The another one question is, the Government of India gave the target of 1,10,000 case notification for Tamil Nadu. Out of 38 districts, few districts got already eliminated status. Few districts still we have more number of cases. There where we are lack of getting notification from government as well as private side. But private sector, you are giving notification incentive that 1,000 rupees per case. Why we are not giving a case notification by our field staff or primary health care staff?
Yeah. So incentives for public sector, right? So one is that you and me who are employees get our salary, right? But like in Tamil Nadu also, the women health volunteers or the male health volunteers or anybody in the community who is a community volunteer, if you collect samples and they send or refer and then they get diagnosed, there is an incentive of 500 rupees. So even in the existing public health system, the most peripheral level field worker can get incentives. It's one awareness about that incentive to them. So when I sat with the ANM to say what is the schemes that you have, so little bit of lack of awareness in terms of her being able to know that what can I do and what will I get, or what will my female health worker get if we do it. So when the PHCMO and the block MO says samples should come in, samples come in, but from where or which population you wanted, and if it is positive, you'll get this additional incentive. So once a few places we could see that also. So they were enthusiastic and they started doing it. So I think probably demand generation from both public health and community side, both sides. Once they know what are the different schemes, incentives, I think surely this can be done.
Thank you, sir. Next question, Dr. Nirmal Jo, Senior RD, sir. How can primary care providers improve early detection of TB in high-risk populations? Who are the high-risk population?
I just want to explain it with a few slides. I'll just go there. Next slide. Next. So, usually when we go to the primary health centers, first high-risk group, I always ask, who are the household and close contacts of the previous index cases? So the TB case is not going to develop from infection to disease within 1 or 2 days. It may take some time. We don't know. Sir, we checked. He was normal. He may develop the disease later on. So I think we have to bring in a concept where we've, just like the post-treated TB we follow up for 2 years, we'll have to bring a concept where we are going to follow up the contacts of these index cases a few months or a few years, so that we see that they develop from the infection to the, or we are also giving the preventive therapy, but still we'll have to check that. That is number one. Second high risk will be our treated TBs. Always our treated TBs are our another high risk. These treated TBs, we have a system now where the guidelines have been given for follow-up. But at the primary care health level, whether the line list of the treated TBs are available for the medical officer to know or for the male health worker to know to follow up that patient for the next 2 years. So this line list also should be available. Next is our pediatric and adolescent. So just now we saw that our NFHS 4 has given SAM, MAM, so many patients, so much percentage. But whether the SAM line list is available at the PHC for the medical officer to screen for TB, this is another point which I wanted to make. So this is one thing. One more thing what I thought was low BMI or stunted patients, pediatric patients in the PHC. Nobody checks for height and weight in the PHC. Maybe we'll have to make a point where the pediatric OPD in the PHC level is checked for height and weight, just like our NCD patients. Next is our undernutrition I already talked about. In the pediatric population, what I was thinking was whether we will be able to bring in a induced sputum type of testing at the block public health unit, which is now being sponsored by our PM ABEAM scheme. So whether if we can bring the induced sputum, which is a very simple way of getting sputum from pediatric population at the block level, then our primary care diagnosis of pediatric population will be good. Next is our alcohol dependence. Alcohol dependence, I think you know that we have so much of patients in the de-addiction clinics, and the government has also now proposed for another 19 more de-addiction clinics. So these types of line list should be available at the primary care level. These are the patients who are admitted in the de-addiction clinics. They also should be screened for TB. And another thing is, in the NCD screening, the checklist which they are having, the NCD screening checklist says history of alcohol, history of tobacco. That is also taken. So maybe we can get those line lists who are giving the history of alcohol and history of tobacco from the NCD clinic and screen them also for TB. So this is one more thing. Regarding our diabetes, I think everywhere in all the PHCs it's being done. Regularly all diabetes patients are being referred. But what I would like to say is all uncontrolled diabetes should be referred for TB diagnosis. That is a must. Next is with reduced immunity. I think this at the primary care level, only the pain and palliative in Tamil Nadu, the pain and palliative unit at the block level is having the line list of all patients who are malignancy, who are on treatment, and they are giving daycare chemotherapy centers at the GH, and they have the line list. Dialysis also, the MTM staff nurse is providing CAPD bags for the CAPD patients at the household level. So even this line list can be taken and they also can be screened for TB. PLHIV, I think we are doing a very good job till now. We screen all of them at the ART centers. Next slide. One more thing, I think ANC. We are having a very good system of ANC screening for all others. But to include the ANC screening for TB, because we have our underweight numbers in our ANC clinic, underweight mothers. So whichever mother is less than 18 BMI can be screened for TB. So this type of screening also we should start at the primary care level. For infertility, now the government of Tamil Nadu has started infertility clinics. So all infertility clinics, they also should be screened for TB. That is number one. Gynec patients who are coming with gynec problems, they also should be screened for TB. Congregate sittings, this is very important. Refugee camps, long-term residential cares, mental health, MR homes, old age homes, night shelters, orphanages, destitute homes, government tribal and residential hostels, all these congregate settings, the PHC medical officer knows which are the centers in his area. So he should plan for a mobile medical unit for a screening in those centers, in those hostels around in his area. Geriatric population now, we are having our MTM. In MTM also we have a line list of the geriatric population where they are going house to house. So that line list also should be used. Mental health. Mental health is another thing. PHC and CHCs are having drugs for all mental health patients. So mental health patients are coming and they are given drugs at the PHC and CHC in Tamil Nadu. So these patients also should be screened for TB. They have seen a very good correlation between TB and mental health illness. Next is viral hepatitis. That is also showing a very good correlation between hepatitis B and hepatitis C. So this line list also should be available at the PHC. Slums at the UPHCs. At the UPHCs, all the urban PHCs are already mapped the slums. So at the slum level, they should have, and at present we are having even our urban health and wellness centers. The urban health and wellness centers are staffed with medical officers and with one staff nurse. With the male MPW male is also available in all urban health and wellness centers. So these male workers also should be utilized for our screening of TB in those centers. Next. Migrants, this is available in rural and in the urban areas. So this also to be done. And the third gender and MSM, I think already we are doing a good job. Last but not the least, I think healthcare workers are missed out in the screening most of the places. So this is also, I think we should make it a very, very important part of our primary screening of. These are all the places where the primary care can be involved in screening for TB to increase our screening numbers. Next. This is another Ayushman Arogya Mandir.
Yes.
I can just go ahead with that. The Ayushman Arogya Mandir or our Nalavalva Mayam. Previous slide. So I think this is one part where we are not able to focus much. Awareness generation in the community. There I think we'll have to use our Ayushman Arogya Mandir for awareness generation. Awareness regarding TB services, health promotion, health seeking behavior. Because most of the barriers, if you say most of the barriers is the concept of drugs in the government sector are not good. The doctors won't be available when we go. So these are all the concept barriers. So cough etiquette, what are the NPY funds which are available? Fixed day awareness program to be concerned in every Ayushman Arogya Mandir. TB champions or survivors to be included in the Jan Arogya Mandir, in the Jan Arogya Samitis. They should be included in the RKSK, the Rogi Kalyan Samiti or the Patient Welfare Society, in Village Health and Sanitation Committee, in Mahila Arogya Samitis, anti-stigma and non-discrimination. This is another barrier in our community. So this also should be, we have a health promotion and health seeking behavior in the Ayushman Arogya which we have utilized for all these community level facilities. Next. So in the CHO and MLHP, like our additional DDG was telling, what all we can use? We can utilize our MLHPs, CHOs in other states and MLHP in our state. Early identification. There is a target for all MLHPs. 20 OPD per day. That is the target. So that target how much of screening of TB they are doing. Whether our WHVs are utilizing our CBACs. Active screening done with other programs. Leprosy is doing active screening. Malaria we do active screening. Sometimes filaria survey is being done. For immunization survey is being done. So many surveys are going on. Whether we are doing active screening along with those survey. Quarterly screening of uncontrolled diabetics. The MLHP is one part of our NCD screening. So they also can be utilized for quarterly screening. Presumptive entry into NICSHI. All the presumptives they can enter into the NICSHI. Sample collection and transport. Tamil Nadu has started IELS. So sample transport for both sputum and for NAT testing. Stocking of anti-TB, I think our additional DDG has already said, stocking of anti-TB at the sub-center wherever MLHPs are available. Next. Public health action, contact tracing. I think nowadays most of the public health action is done by the STS. Or the STS is doing major activity. It is not being inculcated along with the MLHPs or with the MPW male. So a public health action along with the MLHPs, along with the male health worker at the some certain level is very important for contact tracing. In some places we have seen the VHN or the male member will know this patient was here. Sir, he was staying in his grandfather's house for nearly 3 years. The VHN will know. But STS to find that out is very difficult. So that is very important to have. And then they also can follow up the patients for adverse drug reaction. They can also follow up the patient for follow-up sputum, for post-treatment follow-up, for complications. Loss to follow-up patients also can be tracked by the MLHPs. Palliative care at the end. Lot of patients are having destroyed lungs and at the end they end up with, they need some oxygen for some time. Next. See at the UPHC level, Ayushman UPHC and the PHC level, all the other factors have to be taken along with extra is X-ray, utilization of the X-rays. So this we have been always saying, X-ray at the block PHC, the X-ray technician is there or the X-ray is non-functional. Something should be done for availability of X-ray at the block level. If it is not available, some voucher scheme also should be formed so that the patient does not have to go to the district level for the X-ray. DRTB, dispensing drugs using telemedicine. So dispensing of drugs by the UPC medical officer, risk assessment also, and NPY. Next. Thank you, sir. I think I have covered most of the things which can be done from sub-center to the primary health centers. What all things we can do? Thank you.
Thank you, sir. Any question from audience side to Nirmal Jo, sir? Sir, next question to our State Program Officer. As per our Director as well as Honorable Minister declared the floor of the Assembly, we started one-stop TB center each block. What is the plan as a State TB Officer starting from district TB unit to integrate with the one-stop TB center?
So, good evening everyone. So, I thank the director and the entire team that has put a very nice show and a very proud moment for the Department of Public Health and Department of Health as such for organizing to such a huge way. And the same way, so the integration starts from the director here. I would like to answer additional sir that he's invited us to talk about how we are going to start this horizontalizing the entire vertical program of tuberculosis elimination. So thank you for that, sir. Thank you for the question as well, because the one-stop TB solution is something that was conceived and was declared in the floor of the assembly. So this is something to do with the health system strengthening that we want to bring in, where not just the primary health, prevention, promotion and prolongation of life, the three basic, pillars of the public health will be promoted for the tuberculosis patient. This is no longer a vertical program in Tamil Nadu, but we'll be showcasing it to the entire country if we are successful in implementation of this one-stop TB solution. So because as far as tuberculosis is concerned, now we are faced with two major problems, which I would say is something of case detection as well as the mortality prevention. So here and again, when it comes to case detection, the role of primary health centers, as Dr. Nirmal Jo said, it's not just the block level, the sub-block level, the smallest unit, how it is going to be integrated in detection. So this is something we also have evidence, which Dr. Rao very correctly pointed out, that the prevalence survey said we have around 39% of the people in community who are asymptomatic. So if you're going to look for patients who are going to cough for more than 2 weeks, who are having fever, who is going to, there'll be blood and sputum. If we are going to wait for somebody to come with such symptoms, we will be missing cases and our case detection rates will not be as we have increased our examination rates. So this is where every primary health center has to be aware that there is a hidden case in the community. At least for one case, 2 cases that we detect, there is one case that is still in the community that has gone undetected. So we also heard from the previous 2 speakers, so what are the vulnerable population that are there among the community? We also have a line list of something that is already there. So this is where the hidden cases could be, because they are all having, for example, the cancer cases, the immunity is very low. We also have patients who are under dialysis. So all these line lists are there. So where to look for patients? So answering Sir's question, the block level senior treatment supervisor and the senior treatment lab supervisor, so they should be able to share these data among the at the block level, so that the focused case finding happens at the block level in these community to start with. All those line listed vulnerable groups that were presented by the previous speakers, so that has to be focused upon so that we will detect cases from that pool. So having said that, we have to have probably the new interventions, the new technologies that are also there, the handheld X-ray, the artificial intelligence solutions that are available in the handheld X-ray, so that we don't wait for a radiologist to give us the diagnosis or rather screening. So by investing more, so my request would be to invest into these technologies that are available now for TB elimination, achieving the targets.
Another one question about any TB notification. Out of 100 cases, 85 is adult, 15 pediatric age group. Likewise, 75% is pulmonary and 22 to 25% is extrapulmonary cases. Okay. Well, we have only the examination facility, that screening test facility is sputum microscopy. Even with some upgraded PAC, we have X-ray unit. How you integrate your your NHM sponsor staff like STS, STLS, as well as the district coordinator, block level coordinator for PPP program, private notification, so many staffs. Whether any DHO or CHO, any integration between the TB staff as well as your field staff is there in the field? I want to know. Any one of health officer or district health officer, please tell us. Health officer. Mike. What is your notification rate? Whether 100%?
Sir, notification as such, the number of persons identified as TB, for example, last August we had 55 cases for the corporation, out of which only 4 or 5 directly came from PHC, sir. We, after this one-stop center, we started integrating the block level TB stuff, we have very minimum number, 1 STS, 1 HV and 1 LT. Those are the available stuff. Now we have started using our own UHC health inspectors into the picture, sir. What we have tried is, we have a separate mobile X-ray unit and the key population which has been a focus point, like more diabetic cases. So we mobilize those patients and try to put those patients into the screening. Starting from 1 or 0 in the few months, now we have moved on to 4 or 5 cases directly reporting from the PHC, sir. This is an improvement in the last 5 to 6 months what we had in our urban context, sir. Otherwise, we do refer the patients to the headquarters hospital where they confirm and they take it into it, sir.
Why you are not doing at your level? Why you are referring the case to Taluk Hospital,
Sir,
the district headquarters hospital or TB unit?
For confirmation part, we don't have any facilities. We have only
Why,
the sputum microscope.
under ILS you can use. Now recently ILS system you have started.
We have started using it, sir, but it is only weekly, 3 days, the compliance. We have started improving it, but previously we sent most of the patients, and we do have headquarters hospital within the E-Road, DTC within the E-Road, so they easily moved and accessed to the DTC, and that's what the results, sir.
Response from any DHO about TB integration at your level? Salem DHO. இப்போ நீங்களே இன்டகிரேட் பண்ணலன்னா அப்புறம் how can we integrate? அதனால தான் உங்களுக்கு
Good evening all. Actually, we are coordinating with DDTB and his unit. As sir said, we are using IELS. Actually, on the TB cases, on the all diabetic patients and long-term illness patients, எல்லாருமே இப்போ mobilize பண்ணி PHC கூட்டு வந்து, as Dr. Prakash said, வந்து இப்போ TB cases கண்டுபிடிச்சிட்டு இருக்கோம். But once confirmationக்கு STS வந்து அவங்கள வந்து higher center தான் கூட்டிட்டு போறாங்க. This is the reality is going on.
Usually 100 cases you are diagnosed. Now out of 100, 65 confirmed by sputum examination. Remaining 35 by X-ray or TrueNat or CBNat or some other histopathological examination. Okay. 65% of cases diagnosed by sputum microscopy only. Once you diagnose as a sputum microscopy, then the drug sensitivity test only, it will be taken to the nearby TB, the TrueNat availability or CBNat availability. Okay, 65% cases diagnosed at your level. One-stop TB center is enough to diagnose TB cases.
Yes, sir.
Okay?
Yes, sir.
Right.
Yeah.
One question
Maybe
to madam.
Maybe I'll add a point
Sir,
into that.
sir, I like to differ with this point, sir. Sir said it is 65% it is through microscopy, but in field we do not find that much proportion,
We
sir.
analyze the data last 3 years. We analyze the data last 3 years. Out of 94,000, how many detected by sputum examination, how many detected by X-ray, how many detected by TrueNat or CBNat, and how many detected by histopathological examination or CSF analysis? We have the data. That's why I am telling.
Within the sputum, microscopy is only a minimum proportion, and now NAT and
Not like
CBNat
that.
is
Not
I think
like
madam
that.
can add upon.
Madam?
Not across. It's, let me just add into this, So it was wonderful to go to the field the last 2 days in Coimbatore. The mobile van which he spoke of, with X-ray was sitting in the medical college. Why? Because the demand for X-ray is so high that the medical college X-ray unit, it is overflowing, and their patient will have to go somewhere far and come back again. So the mobile van is placed in the medical college to top up on the X-ray. So yes, enhancing our X-ray is important, but mobile van was supposed to be in the community. That is why it is mobile. So that's one thing. But in terms of sputum microscopy as the primary tool for diagnosis, it's around 70%, and we have to move that slowly. So very recently in Tamil Nadu now we have TrueNat now at all block levels, right? So the sample that is collected, it can easily be transported. Currently, sample transportation mechanism, one is with what Madam said, the ILS, but very limited. Only 2 days a week and only going for this sample. But otherwise, it is the female health volunteer or fixed days, somebody will come in. So I think there is a need for one, decentralizing the diagnosis Because if you rely on sputum microscopy, like Dr. Asha said, half of the cases are asymptomatic and you wait for them, sputum microscopy, you miss another 25% because the sensitivity of the tool is minimal. So what is happening is, all the 10 people who had to get that infection have already got it, right? So it's late diagnosis, so transmission continues. Your number of cases in the district continues to be the same year on year. Prevention is currently restricted only to the households. So that's one thing which I would want to suggest, that you need to now expand TB preventive treatment to the population which is vulnerable but outside the household. As of now, only contacts and PLHIV is the only population which may probably get it outside the household. So that is where I think a lot of new cases, prevention can happen, and which will have an impact on mortality directly. Right? So that's one population, be it diabetics, CKD, low BMI, all the population which are just showed there. Right? So have the state level committee and decide on which population you want to do. There is surplus drugs, full flush drugs available. So take that call and then you can move forward, on that part. Yeah. Thank you.
Sir mentioned that the latent TB as well as asymptomatic TB. Question to STO. What are the screening methods to detect asymptomatic as well as latent TB cases?
So, for a latent TB infection, now that we have something like, we must have heard of Manto test. So, we have another a test that has come up called CYTB, which is been, the supplies have reached the state. So, we would be utilizing CYTB for all the population that is vulnerable, clinically vulnerable. So, when I say clinically vulnerable, so the patients that are with the low BMI as a contacts of TB patients, not just the household contacts, and the immunity. So people with low immunity, the patients on chronic kidney disease who are on immunosuppressives for cancers and anti-cancer therapy. So these are the pool of patients that we also have, which are liable, clinically vulnerable to contract TB. So these, we will start with that, and as suggested, we'll have a state level committee, and we'll deliberate on after that we'll draw the SOPs into integrating that. So as far as latent TB infection is concerned, there is something, the other pool, as I said earlier, the asymptomatic pool is also there, because they do have, as per the prevalence survey, changes in the X-ray, but there is no cough. It is dry. So that pool has to be gone. You can detect only through an X-ray, and further maybe induce sputum, and there are other methods to bring out the sputum. Otherwise, we have to go with the X-ray screening of such people. For latent TB, we have something right now in our midst, which is a CYTB, a very new tool, but a time-tested and a proven tool.
Okay, thank you, madam. The next question to Mr. Rajeswaran sir. What role can primary health care providers play in educating communities about TB prevention and treatment?
Yes. So I would like to answer this question. I have a slide from our own experience actually. Slides. Okay. No issue.